Okay, so we finished on the last video talking about the platelet plug and the steps involved in that. So as we said, platelet plugs can actually close off, conceal, they can seal off small breaks in vessels, but it can't seal off large vessel breaks. But luckily, we do have a mechanism for sealing off much larger vessel breaks, which is the blood clot. And so now we're going to talk about how blood clots form. Okay, so the blood clot is a network. So here you see kind of a larger break, and then you see the clot formed in the break, sealing it off. And a clot is basically a network of a protein called fibrin with a bunch of activated platelets inside of it, right? Activated platelets, platelets got activated by the vessel break, and so you've got all these activated platelets kind of trapped inside, as well as red blood cells. So the platelets, as we'll see, are they actually play an important role in the formation of the blood clot, and in some of the steps, particularly in clot retraction that happen afterwards. Red blood cells just get caught up in the clot by accident. The reason why clots look red is because they have red blood cells in them, but the red blood cells are totally non-functional. They don't have any functional role in the clot. They just kind of happen to get caught up in the network. Okay, so fibrin, this network of fibrin, that's the key thing really that is what makes a clot. So where does this fibrin network come from, and how is it formed? So fibrin starts its life not as fibrin, but as a larger protein called fibrinogen. And fibrinogen just floats around in the blood all the time. It's not sticky, it doesn't stick to itself the way and doesn't form a network. It just floats around in the blood. It's just always floating there. We did actually encounter fibrinogen already, because one thing it does is it helps the platelets to stick to one another during platelet plug formation. So that's one role that fibrinogen has. Fibrinogen is made by the liver. So the liver is just always pumping out fibrinogen into the blood. And this is one of the reasons why if you have liver disease, you actually have problems. One of the big problems with liver disease, you have problems forming blood clots because you're not making enough fibrinogen. But so fibrinogen, as we said, doesn't make the network. It's pretty much just a non-functional protein. However, fibrinogen can get cleaved into a smaller protein that's called fibrin. And fibrin is very different. Fibrin is very adhesive to itself. As soon as fibrinogen is cleaved to fibrin, the little fibrin molecules immediately stick to one another and form a network, the fibrin network, and that's basically the key, the core of the blood clot. So the conversion of fibrinogen to fibrin is really the key step in the formation of a blood clot. And so now the question is, what causes that? And the answer is that there's an enzyme in the blood called thrombin that can convert that can break fibrinogen down into fibrin. And when it does that, so that's what's responsible for the formation of the blood clot. Now, thrombin, it can only do this when it's in the active state. So this little star by the thrombin is meant to indicate that this is activated thrombin. So activated thrombin breaks fibrinogen down into the fibrin, breaks fibrinogen down into fibrin, and fibrin then forms the fibrin network, which is the core of the clot. So, if we started by saying, well, what causes a blood clot? And the initial answer was blood clots formed when fibrinogen is converted into fibrin, which then forms a fibrin network. And now we say, well, what does that? And then the answer is activated thrombin is responsible for doing that. So thrombin. So now we want to say, well, where do you get activated thrombin? So thrombin is found in the blood all the time in a non-activated state. It's often called prothrombin. So non-active thrombin is also called prothrombin. So thrombin in the non-active state floats around in the blood all the time, kind of like fibrinogen does, and fibrinogen floats around, and you know, prothrombin floats around, and the two guys sort of float by each other and don't have any interaction normally. And then something turns on thrombin, activates thrombin, then the activated thrombin grabs fibrinogen, breaks it into fibrin, and the clot forms. So now we can sort of, you know, our story is sort of building, right? So clots are formed when fibrinogen is converted into fibrin. That happens when prothrombin is converted into thrombin. So the turning on of thrombin, the activation of thrombin is now that's the key step that we can see is responsible for then the sequence that then leads to a blood clot. So activation of thrombin is the key event triggering blood clot formation. What activates thrombin? And the answer is ta-da! So highly complicated series of reactions. I certainly don't expect you to memorize this, but so first of all, there's a series of reactions that can take place in the blood. And this series of reactions is called the clotting reaction or the coagulation reaction. Okay. So, and you can see that there's a lot of stuff in this picture, but there's a few aspects I'm going to sort of draw your attention to. So, you know, let's think about kind of what's happening in this picture. So, first of all, as you can see, there's kind of two pathways, and we'll talk about that, what that means in a bit. So, you know, tissue damage or, you know, damage of blood vessel basically trigger this series of reactions that end up leading to the activation of thrombin, which then makes fibrin and fibrin clot. So that's kind of what this picture is showing. But obviously there's a lot of stuff going on, a lot of steps. And so the first general principle I want you to see here is that that basically there are a lot of the clotting reaction involves a sequence of steps involving a number of different what are called clotting factors. So, you know, clotting factor 7, clotting factor 9, 12. There's a bunch of clotting factors that are involved in the steps that lead toward thrombin activation. And I don't want you to memorize any of the individual clotting factors or individual steps, but what I do want you to just be aware of is that you need all these clotting factors to get from the initial injury to the clot. Okay, you have to have these intervening factors to get to the final formation of the clot. So clotting factors are necessary in the formation of a blood clot. So these clotting factors are proteins. They are made by the liver, and many of the clotting factors that you see on this slide rely on actually a certain vitamin called vitamin K for their synthesis. The liver needs vitamin K to make most of these clotting factors. First of all, that there are a number of genetic diseases where people fail to make one or more of the clotting factors, usually just one, like they have like a factor 8 deficiency, genetic deficiency, and those people have that's one of that's a major cause of hemophilia. So if people who have hemophilia, and if it's a genetic disease, usually it's because they have a genetic problem making one of the clotting factors. And then the other thing that's important about the synthesis of clotting factors, so I mentioned that many of them rely on vitamin K to be synthesized. So there's a drug called Coumadin, also known as warfarin, as in warfare. It was developed initially actually as a rat poison. Now it's a very commonly used medication. What Coumadin does, and I'm sure some of you know people who are on Coumadin. So Coumadin blocks the vitamin K utilization by the liver, and it prevents clotting factors, or reduces the level of clotting factor synthesis. And so what it's used for basically is for people who are making too many clots. If you get a big blood clot, or if you're prone to clotting, you may have to be on Coumadin. You may have to, your doctor may prescribe Coumadin for you, and you have to sort of take it, every day. But the problem is Coumadin's it's a crappy drug. It's very delicate. And as you can imagine, if take a little too much Coumadin, and the reason why it works as a rat poison is that you can completely knock out your clotting factors, and then you are now you have hemophilia. You have way too high of a risk of bleeding, right? So this drug was prescribed to you because you were clotting too much, but the drug can cause you to not clot enough and can kill you in that way. And so people who are on Coumadin have to have their Coumadin levels in what's called their INR, which is kind of a check of their clotting ability. They have to have these things checked like weekly or more to make sure that their levels aren't getting out of whack, because it's very, very dangerous. You have to have, when someone's on Coumadin, you have to have their levels be just high enough, but not too high. And it's hard. It's a hard drug to deal with, but it's very effective, and it's one of the most effective drugs we have to give to people. And you can give it to them as a pill, and it'll last for, it'll last for an entire day. Unlike some of the things that we use only in the hospital that I'll talk about in a minute. Okay. And then actually an interesting sort of clinical pearl. So something that happens a lot in the hospital. Someone's on, being treated with Coumadin because, say, they had a stroke or a heart attack, and so their doctor prescribed them Coumadin to reduce their clotting. They come in, and you notice that their clotting ability is like nil. They have no clotting ability because their Coumadin levels have gotten too high. One very effective. So Coumadin works by kind of blocking vitamin K uptake by the liver. So basically, the best way to treat a Coumadin overdose is to give people really high doses of vitamin K to provide huge amounts of their liver, so that their liver can then take up some of that vitamin K. Even though the liver is not doing it very well, there's lots of vitamin K around. They can take it up and use it to make the clotting factors they need. Okay. So that's the first general point I want to make about this slide. Second thing is that, as we kind of pointed out, there are these two separate pathways that can both end up, basically activating thrombin. One's called the extrinsic pathway, one's called the intrinsic pathway. So in the extrinsic pathway, let me start with the intrinsic pathway. The intrinsic pathway is the pathway that involves platelet activation. Okay, so damaged, collagen and things like that in the blood vessel wall activate platelets. And when platelets are activated, so remember we talked about activated platelets release these signals into the blood. So those signals, if they're present at a low level, all they do is basically bring more platelets to the site. But if these guys get to a really high level, they actually can trigger the intrinsic pathway of the clotting reaction. So the basic idea is, say if you have a little vessel break, you get a few platelets coming to the site, you get a few platelets being activated, they release, a small amount of this, enough to activate some platelets, but that's about it. Then they close up this little break and it's over. And this stuff goes down and you get your platelet plug and you're done. A big vessel break, huge vessel break, whole bunch of platelets will come in, get activated. Whole lot of this, these signaling molecules will get released. And when these signaling molecules released are released to a high enough level, suddenly they now will kick in this whole second sequence of events, which is the intrinsic clotting pathway. And this is one of the two ways that a clot can be triggered. So if there's basically a big enough break, enough activated platelets can kick in this intrinsic pathway and come down and get activated thrombin, which then makes the fibrin clot. But then you also have what's called the extrinsic pathway. So in the extrinsic pathway, damaged tissue releases molecules into the blood, as we said, and these tissue molecules, if they're at a high enough level, can trigger the clotting reaction to occur even without activated platelets. So the extrinsic pathway does not, so no platelets required for the extrinsic pathway. And the basic idea here is just to provide some redundancy, okay? So people whose platelet levels start to drop, they will definitely show, they will not be able to form platelet plugs, and so you'll definitely see these kinds of things, petechiae, inside and out. But, then ask yourself, someone who's low on platelets, will they be unable to form clots? And say you're completely absent, so say you have no platelets at all. Is it possible for you to still form a clot? And the answer is yes, because you have this extrinsic pathway. And if there's a big tissue break, it can release enough tissue molecules to trigger the extrinsic pathway, even in the absence of platelets. It's not nearly as effective as it would be if you had both pathways together. So you're clotting, you're still going to be, basically you're still going to be in a state of hemophilia, basically not clotting as well as you should if you don't have platelets, but you're not going to be completely lacking in the ability to make clots. This sort of double pathway gives you some cushion in case your platelet levels drop too low, so you don't lose your ability to make clots altogether. And then the final point that I want to make about this slide is something I've just kind of already alluded to, but anyway, just notice that regardless of how you get here, whether it's extrinsic versus intrinsic, ultimately the key final step in the formation of a clot is the activation of thrombin, turning prothrombin into thrombin, and thrombin then makes the fibrin clot. So regardless of how you get there, the thing that the final common step of all these pathways is turning on thrombin, which then activates the clot. Okay, so one question you might be thinking is, well, why is this so dang complex? Why are there so many? Why is it, come on, where's that dang cursor? Why doesn't platelet activation directly cause thrombin to get turned on? Why do you have so many intervening steps? And the answer is that it basically provides a lot of places where you can, maybe put the brakes on, or at least somewhat regulate the process. So one thing that you don't see in this image is that basically every single one of the steps involved here in the clotting reaction, both intrinsic and extrinsic, there are molecules that are out in the blood that can come and actually stop the reaction. And these are called anticoagulants. And so your clotting system is always kind of it's being pulled in two directions at once. You've got the clotting pathway that makes it maybe tend to want to make a clot and kind of having this clotting reaction move forward. Then you've got the anticoagulants floating around that are putting the brakes on it all the time and preventing those reactions from moving forward. And normally, in the normal flow of blood, the anticoagulants are really winning. The clotting reaction isn't moving forward. The anticoagulants are putting brakes on everything. And it's only when either one or both of these pathways gets turned on to a high enough level that they can that the reaction can move forward and overwhelm the anticoagulants that are trying to stop it. And that's sort of this, this idea that, we're always trying to be, our bodies are kind of having us try to be poised between, forming a clot and preventing a clot. And this, having multiple different steps here provides a lot of places where the whole process can be regulated, and it gives a lot of power to our bodies to sort of be, careful in how we turn up or turn down the clotting process. And I want to point out a couple of important anticoagulant molecules. So there's a molecule called antithrombin that can basically break thrombin down, can just cleave thrombin and inactivate it. It's always floating around the blood, and it basically breaks down thrombin whenever it finds it. And then there's another molecule always floating around in our blood called heparin, whose job is to kind of basically activate antithrombin. So heparin activates antithrombin breaks down thrombin, and this is just one of the many anticoagulant systems that we have in the body. But the reason I'm drawing your attention to this one is that heparin is another really important drug that's used clinically. So if you give somebody heparin, say a high dose of heparin, it activates their antithrombin pretty strongly. Think about what that would do to their clotting. Would it make them clot more, or would it make them have less clotting? The answer is less, right? So antithrombin breaks down thrombin. So heparin activates antithrombin, and therefore that causes a lot of the thrombin to get broken down, and therefore less clotting. So heparin is also a pretty potent anticoagulant. So it's got some pros and cons. So we said basically the other one we talked about was Coumadin. Coumadin is an anticoagulant that basically prevents coagulation factors from being made or makes them being made at a lower level. Coumadin is something you can take as a pill at home. You can take it once a day, and you don't have to be in the hospital for it. But it's kind of dangerous, right? You can easily get out of balance. Heparin, on the other hand, the disadvantage of heparin is that it doesn't last very long. You couldn't take it at home because it has to be given IV, and it only lasts, basically, if you once you stop the infusion, the effect wears off in about half an hour. So you couldn't take it at home. You can only do it in the hospital. But it's actually a beautiful drug to use in the hospital because, think about a hospitalized patient, and they say someone comes in for belly pain, and you think they're having that maybe an infection, and you're giving them antibiotics. You don't think they need surgery today. But you pretty much have to kind of worry about clotting with all of your patients. So you give them some heparin to reduce their chance of getting a clot. So So you have this patient who's on heparin, and pretty much all the patients in the hospital all the time are on heparin, just to minimize blood clots. One thing I didn't really talk that much about, but one of the things that can make you prone to getting a blood clot is if the blood just isn't moving as well as it should. So people, if you're on a long plane ride or a long car trip, or especially people who are in the hospital, they're not moving around as much, so they're not getting their blood to pump as much, and that puts you at a high risk for clotting. So pretty much all the patients in the hospital are on heparin, okay? But you have this patient on heparin, and let's say all of a sudden, oh my God, you realize that they're bleeding into their belly. Well, if you were giving them Coumadin, you'd be in big trouble, because you can't stop Coumadin very quickly. You can try to giving them a big dose of vitamin K, but it's actually pretty messy. It doesn't work. That doesn't work very well. But heparin is fantastic. You turn it off. Half an hour later, the effect of heparin is gone. If you need to take them into surgery, they'll be fine. So it's a really great drug for the hospital. Sometimes people have to be on both when they're in the hospital, but heparin is can only be used in the hospital, and it's really it's got short time. It only works for a short time, but it wears off really quickly, and that can be really handy. Okay. All right. So we've got our blood clot. So let's talk about now. Let's talk about then just sort of the last stage, what happens after the blood clot is formed. So we have, this sort of shows the stages from beginning to end. So clot initiation due to platelets, and then you get the clot formation. So we've got our fibrin clot here. So there are two things that happen after the initial clot formation. So the first is a process that we alluded to a little bit called retraction. This happens kind of minutes after the initial clot formation. So the clot forms, and then within a few minutes you get clot retraction. And clot retraction is this process we talked about where the platelets that are inside the clot, the little platelets actually contract due to actin and myosin, causing the clot to retract, to become smaller, and that basically, as the clot, as this clot gets smaller, it helps seal off the wound, and it brings the edges of the tissue closer together. Okay, so retraction happens within minutes. But then, if you get a wound and you get a blood clot, you of course don't want that clot to be there forever. You want eventually to be able to try to get rid of the clot and start to try to replace it with tissue. So you need to break the clot down, and that process is called fibrinolysis. Sorry, look at this misspelling. Never noticed that. Lysis. It happens kind of hours to days after the initial clot is formed. So fibrinolysis means breaking down fibrin. Okay, so the fibrin is broken down and the clot basically just dissolves. And the key to making that happen is yet another molecule in the blood called plasmin. So plasmin is a molecule that can break fibrin into basically just, little pieces of protein that don't stick together and basically causes the clot to dissolve. So plasmin breaks fibrin down into fragments and causes the clot to dissolve. So plasmin, and again we see the theme that we've been seeing in a lot of these proteins, right? It basically floats around the blood in an inactive state called plasminogen. Plasmin is the active form. So plasmin can break fibrin down into fragments. Plasminogen can't. So now we want to say, well, what's responsible for breaking for converting plasminogen into plasmin? And So plasminogen gets cleaved to become plasmin, and the cleaving of plasminogen into plasmin happens by a few different molecules. So thrombin is a big one that actually, does it. So it's interesting. Thrombin causes fibrinolysin to turn into fibrin. It forms the clot, but thrombin also turns on plasmin, which will eventually cause the clot to break down, right? And that kind of makes sense. The same molecule that causes the clot to form also begins the process of that clot being broken down. But then one of the things that's kind of interesting is that there's also, so one of the clotting factors also participates in converting plasminogen to plasmin. And then there are some other molecules that also facilitate this. And again, there's sort of one that's of clinical importance. So TPA is tissue plasminogen activator. And it's just one of the blood molecules floating around that can help convert plasminogen into plasmin. But TPA is also used as a drug. And so let's think about, if you give someone, let's say, a whole lot of TPA, is that going to make it so they clot more or clot less? And that's actually kind of a bit of a trick question. So if you give someone a high dose of TPA, you won't have changed their ability to make the clot, so they can still, do all this and their clot gets formed. But TPA facilitates the formation of plasmin, so the clot will be formed, but then it will get rapidly broken down. So people who, if you give someone a big dose of TPA, it'll make it so any clots that exist will get broken down much more rapidly. And so can you think about any circumstances where you might want to give someone TPA? And the answer is that, so basically the two circumstances where TPA is used is basically in myocardial infarction, which is basically a heart attack, a clot in a vessel in the heart, and stroke, which is a clot, usually anyway, a clot in the brain. So people who get these blood clots that block off arteries to vital organ, either the heart or the brain, one of the treatments you can give them is to give them TPA, and TPA will make it so their body will break those clots down much more rapidly than normal. And it works pretty dang well. In fact, sort of the big challenge with TPA is it works all too well. So, you give someone a big dose of TPA and they're going to actually have real problems clotting for quite a while. And so you have to be pretty careful. It turns out that these days for the heart, it's almost never used unless, the only time it's really ever used is if someone's like way out in the boonies and they really can't get to a hospital. But there are some sort of mobile docs who have access to TPA, and they'll use that with somebody who has had a heart attack and really can't get to the hospital. But if you can get to a hospital, TPA is really not the best choice. There's basically what they do is they put a wire up in your heart and just physically break up the clot and then put a stent in place. And we'll talk about sort of how they do that. Because it's just too dangerous to give TPA. They've shown that people just don't do as well in the long run with TPA as they do if they get their heart, a heart catheterization. In the brain, you can't really catheterize as well. Occasionally you can, but most of the time it's in some really small vessel that's really not accessible to putting a wire in. So TPA is used for strokes. If people have a clot in the brain that's causing them to have a stroke, TPA is used. But you have to be really careful about using it. So basically, there are rules about when you can use it, and it has to do with it has to be used only if someone's had a stroke very recently. And if you're not sure when they had the stroke, you can't give it. And if you think the stroke happened more than like half an hour later, or like half an hour ago, if someone comes in and you basically, when someone comes in with a stroke, one of the first things you do is try to figure out when their symptoms started. And if it was more than about half an hour, you can't give TPA, because here's the thing that what can happen. If the person's had a stroke for an hour, they had the stroke, right, the blocked off vessel, but then the tissue, downstream of that vessel dies. So you have a clot, and then you have sort of dead tissue around it. you don't have healthy tissue, you don't have a nice healthy vessel anymore. So you give that person TPA, and here's what happens. You break that clot, the blood starts flowing, and then the blood flows into this dead spot in the brain, and you get a big bleed into the brain that ends up making things way worse than they would have been if you would have just left the clot there. So they're really strict in stroke treatment about only treating with TPA within a narrow time window. And they argue, kind of go back and forth about how wide that time window is. But anyway, just kind of sort of illustrating the power of TPA. And how it can be really useful, but it's also can get you in trouble. So I've got a section here at the end of the lecture on blood transfusion and blood grouping. I'm actually going to skip that. We're not going to have that. We're not going to cover that material. It won't be on the upcoming exam. I think there's a question on homework 4 about it. I will give you full credit on that homework if you don't answer the question, and if you answer the question, then good work, but it's not required. Okay, so thank you very much. Enjoy the rest of your day.